Hello and welcome to ID Talk, Answers from Infectious Disease Experts. I'm Dr. Nathan Price, a pediatric infectious diseases specialist at Banner University Medical Center, Tucson, and associate professor of pediatrics at the University of Arizona College of Medicine. With Dr. Scott Olson, I'm the Arizona AAP Infectious Disease and Immunization Co-Medical Director. This podcast has been created to answer questions from our chapter members about anything and everything infectious disease and immunization related. Thank you for tuning in today. This is the week of February 23rd, 2026. So let's get to the questions. The first question is, we often see both mycoplasma and monospots or EBV serologies that test positive in the same patient. Is there cross-reactivity in these tests? P.S. They were done for fatigued kids with coughs. So this is a great question. First things first, though, I'm not aware of any data that shows cross-reactivity between EBV and mycoplasma serology. In theory, there shouldn't be cross-reactivity because they're very different organisms. Sometimes you can see cross-reactivity with some tests if there's similarity between the organisms, like, for example, coccidioides or histoplasma serologies, and RPR can react with other treponemes. But also, sometimes our tests can be falsely positive, and IgM in particular can be problematic sometimes, with false positives in the setting of other inflammatory conditions or infections. Let's talk a bit more about these tests in these diseases in general. The patient that has fatigue and or cough is often a challenging one, and we want to get the diagnosis because we want to know where things are going to go, and we want to know what it is we should do about it. And there are many infections that can cause a cough that can linger, and there are many infections that can lead to fatigue that can linger as well. Unfortunately, many times we never actually get the diagnosis, but the good news is that fatigue related to infection usually gets better over time, but it can take a while. The improvement is often incremental, and so I'll often ask my patients, what percentage is your energy today compared to what it was a month ago? And then if it's been going on for many months, what was it each month before that? And often you can see that there's this slow improvement, and that's reassuring to me and the patient when you are able to recognize that. EBV is an infection that can lead to cough and fatigue, and both of those things can last for a while. And in general, coughs can wax and wane. And with fatigue and with cough, you can also get new things on top of that make those things get worse. And, having a careful examination, having a careful history can help sort that out. But it's also important to remember that there are non-infectious causes of those things as well. Most lingering coughs will be due to something that's self-limiting. I usually go looking for tuberculosis or coccidioides if things aren't making sense or not getting better. And of course, mycoplasma can take a lung to improve as well, and you can use diagnostics to help sort that out, but they can be problematic, and we'll talk about that here in a minute. The monospot test for EBV is a heterophile antibody test. They used to use it with sheep blood, but the newer tests use horse red blood cells to see if the antibody causes agglutination. It's often used as a screening test because it can be easy to do and rapidly available in some labs. It can also cross-react with other viruses of the herpes virus family and other viruses from other families. It's also positive sometime in other situations where you have inflammation, like autoimmune diseases. It can also be falsely negative in about 25% of patients, and there's a high false negative rate in children under the age of 4, so it's not generally recommended to be used in that age group. Heterophile antibodies usually are positive by the time of onset of symptoms, and they can stay positive for weeks to months and sometimes for a year and longer. A positive heterophile antibody test should be confirmed using other antibody tests if things aren't making sense for the diagnosis. EBV serologies include IgM for viral capsid antigen or VCA and IgG for VCA, as well as antibody against Epstein-Barr nuclear antigen or EBNA. There are also some early antibodies that are used in some of the older serology tests. The IgM for VCA is usually positive at the onset of symptoms and certainly should be positive within a couple of weeks of symptoms, and it can stay positive for weeks to months and again, sometimes off and on for a year or longer. The IgG tends to show up fairly quickly as well, but usually after a couple of weeks of infection, and then stays positive usually for the rest of your life, but it sometimes can wane over time. The early antigen tends to show up within a few weeks, stays positive for a few weeks, and then tends to wane over a short period of time as well. EBNA, or antibody against Epstein-Barr nuclear antigen, tends to show up months later and also stays positive for a long time, including up to the lifetime of the patient. So the key to looking at EBV serologies is the EBNA. If the EBNA is present, then the infection occurred likely months ago, and so any acute findings that you're seeing in the patient probably is not due to acute EBV infection. On the flip side, If you have a positive IgM and possibly positive IgG but without the EBNA, then your infection probably has occurred quite recently, and acute symptoms that you're finding may have something to do with acute EBV infection. Many people fall into the trap of saying that your symptoms that have been going on for a somewhat short time to a little bit longer than average are due to EBV, even in the setting of a positive EBNA. So yeah, sure, if you have an IgG that's positive and an EBNA that's positive and you've been having fatigue for many months, it's possible that EBV caused those symptoms because, again, it's been going on for months and EBNA shows up for months. But if you have a negative IgM, especially in that situation, it's just as possible that that patient had the EBV infection many years ago and it has nothing to do with what's going on today. And at that point in time, we don't really have a great way to sort it out one way or another. You may be tempted to get a blood PCR looking for viremia, but even that's not reliable because perfectly healthy people can have intermittent viremia without any symptoms at all. And that's because the virus lives in your lymphocytes and can show up from time to time, even if you don't have any symptomatology at all. So mycoplasma is a somewhat similar story in that it's a little difficult to interpret the testing results in the clinical situation sometimes. IgM shows up early and lasts for a short period of time and then generally wanes over time, but sometimes it can be positive for weeks to months and every once in a while for years. IgG tends to show up a little bit later and it tends to last a lifetime, but it also can wane over time. You can get PCR from various sites depending on the clinical situation. A lot of the respiratory viral panels and other expanded panels have mycoplasma PCR on them. You can also get PCR from other bodily fluids, including CSF and pleural fluid and things like that. Again, it's difficult to interpret and you need to look at it in the clinical situation. From a sterile site, it makes sense that a positive PCR is probably legitimate because you shouldn't see it there. But in your nasal secretions, you can shed DNA for many, many weeks. And of course, there's always the slight possibility that the person preparing and doing the test was shedding from their nasal secretions and that contaminated the test. That should be pretty rare, but it's something to consider. When you look at the literature in mycoplasma, there's a lot of case reports of it doing lots of things. And while it certainly can do a lot of things, I'm always a little suspicious based off of some of those reports. Again, a lot of them are interpreting in the setting of an IgM that's positive for many months or a PCR that could be shedding for weeks. And so you have to take some of those things with a grain of salt sometimes. When it comes to mycoplasma, antibiotic therapy may ameliorate symptoms. There are some studies out there to suggest that treatment may not be beneficial for some patients. But generally, if I have a patient that clinically looks like mycoplasma, and especially if you have a positive test for it that fits the situation, then I generally treat with antibiotics. So getting back to that original question of, cross-reactivity, no, I don't think there is cross-reactivity, but it is certainly possible to have more than one infection at a time. And it could be that one was older, one was newer, or they both are happening at the same time because those things certainly can happen. Okay, on to the next question. Could you please clarify the early MMR dose for infants based on the recommendation to vaccinate at 6 to 11 months rather than 12 to 18 months? Is this a state or regional recommendation? So another great question, and one that we're going to see a lot more of in the coming days, because we need about a 95% vaccination rate to prevent the measles outbreaks that can happen in communities. So that rate has been going down throughout the nation and here in Arizona. And so it's not surprising that we are going to see more and more of these outbreaks happening. And even if we don't have outbreaks, you can have sporadic cases that are brought in by travel. And of course, vaccination is so important because it works and because the measles disease is incredibly contagious. It's transmitted by airborne droplet nuclei, and you really don't have to be close at all to a person and get the measles because those particles stay suspended in the air for hours, and you can walk by later and pick it up. And if you're non-immune, it's got a really high attack rate. And unfortunately, measles has consequences. 1 to 3 people in 1,000 that get infected will die. And of course, lots of other sequelae that can happen and can cause permanent problems for people. The vaccine works really well. The first dose that we generally give around 12 months of age is 93% effective in preventing infection. The second dose that we generally give at 4 years of age is 97% effective. It's important to recognize that that second dose isn't a booster. It's to catch those people that didn't respond the first time. In times of generally good coverage of vaccine in the communities, we would give that first dose at 12 months of age, and it would be fine to wait for 4 years of age to get that second dose. But if there is concern, you can give that second dose earlier, and you can give it as soon as 4 weeks after the first dose has been given after 12 months of age. The MMR efficacy can be affected by circulating maternal antibody, and so that's part of the reason we don't usually give MMR vaccination before 12 months of age. But in outbreak situations or in situations where there's a high risk of known exposure, say travel to an endemic area, then you can give the dose of MMR to 6 months of age through 11 months of age to give that extra protection. Since it's not as reliable, it doesn't count towards that 2-dose series. And so if you give a dose during that age period of 6 to 11 months, you still need to give the 2 doses after 12 months of age as per the regular schedule of vaccination. With outbreaks that are happening with local transmission in Mojave and Maricopa counties, those health departments have recommended giving that dose at the 6 to 11 month of age to give extra protection to those infants before they hit 12 months of age. Since there isn't ongoing transmission possibly yet, in other counties it's not recommended to give doses at 6 to 11 months of age in those areas. You can consult with your local health department and see in real time what's happening to confirm that. Of course, if an infant in that age group has a high-risk situation, has been exposed, or is going to an endemic area, then yes, you can still give that dose during that time frame, but remember, it doesn't count towards that 2-dose series. It only counts once you give 2 doses more than 4 weeks apart after 12 months of age. So it will be interesting to see what happens if we become an endemic country once again, and what will happen with that 6 to 11 month dose recommendation. More to come, obviously, and keep up the good fight for helping folks get vaccinated, because that's what's going to make the difference here. All right, next question. Can you speak about the data for the 2025-2026 flu season and any changes you have observed compared to prior years? So as you well know, each flu season is different, and that's because the virus is constantly changing with genetic shift and genetic drift. Some years, prior immunity from prior infection or prior vaccination carries over and helps protect some, and other years not so much. And in those years, we don't generally have a good match with the vaccine because of those changes that the virus makes. The good news is that one way or another, if you get vaccinated, even if it's not a great match, there's still some protection against severe disease, including hospitalization and death. So it's worthwhile to get vaccinated, even if it's one of those quote-unquote not a great year. We generally get an idea of the current flu season from the southern hemisphere because that's generally where that season starts, and then it makes its way up to us. So early reports seemed like it was going to be a worse than average flu season this year, and it seems like that's the case. There's a new subclade of H3N2 that has showed up that's not as great of a match for the vaccine, but there are studies showing that people who have been vaccinated are making antibodies that have some neutralizing activity against that subclade. So again, more good news that getting the vaccine still makes sense. The WHO and the CDC collect data on influenza every year, and the CDC has a really rather nice website that gives lots of influenza information. And if you just type FluView in your browser, you can find it pretty easily. And if you have any questions about flu and how things are going, I highly recommend that you take a look at it. With recent changes in the administration and funding, and with the recent shutdown, there may be some limitations to the data that's being collected and how often it's being looked at. But again, take a look at the data and see what you can see for yourself. It seems like this year's flu season may have peaked around the end of December, and rates continue to decrease, but it's important to recognize that there definitely is still flu activity out there. We're still seeing children being admitted to the floor and sometimes to the ICU with influenza infection. Looking at the last few years, this season seems to be a little bit lower when it comes to pediatric mortality. In 2022, there were 187 pediatric deaths, 2023 had 210, and 2024 had 290. This year we're up to 71, but again, the season is not over yet. Historically, about half the deaths of children with influenza occur in children who don't have other comorbidities. So again, it's a good idea to get vaccinated, even if someone seems like they're perfectly healthy. Anecdotally, it's still a rough time from a respiratory standpoint. Our pulmonologists tell me that they are still quite busy with a combination of asthma, allergies, and viral infections. Okay, that's all for the submitted questions for this month. But before we finish, I'd like to talk about the hepatitis B vaccine, and specifically the birth dose of that vaccine. So as I'm sure you're aware, ACIP recently stopped recommending universal hepatitis B vaccination at birth. They stated their reasons for this, but as we're going to discuss, I think this is a bad idea. In the Journal of Pediatrics, there's a brand new, very well-researched and written review on the birth dose of hepatitis B vaccination. I highly recommend that you familiarize yourself with it. But I'll summarize the key points for you today. So let's go over the ACIP recommendations. They said that among women who screen negative in pregnancy, that parents can decide in consultation with their providers when or if to vaccinate their child for hepatitis B, and if not at birth, then no earlier than 2 months of age. They also say to consider collection of infant immune titers to guide decision-making for completing the vaccine series, and that insurance should pay for that. So like a lot of the vaccine suspicious questions and recommendations by various people out there, the reasoning can seem plausible at first, but dig deeper and you'll see why this isn't a good idea. So let's talk about the ins and outs of hepatitis B so we can better understand the context and the meaning of how these recommendations may or may not work. So we know that hepatitis B can be transmitted various ways. It's really a blood-borne pathogen, so you can get it through blood products, although we're really good at screening blood products these days. You can get it through needle sharing. It can be transmitted sexually, and it can be transmitted mother to child. The virus is quite hardy and can stay viable on surfaces for several days. There are many ways to help mitigate the risks of transmitting hepatitis B, and risk avoidance is certainly one of them. But it's important to remember that people still get hepatitis B without having any known risk factors. So vaccination still remains the best way to prevent getting infected with hepatitis B. If an infant acquires infection perinatally, that infant has a 90% chance of developing chronic hepatitis B infection. And this is a problem because 25% of those people die early, and they die from things like hepatocellular carcinoma or liver failure or other complications related to that. And while there are antivirals available, they don't work very well. So hepatitis B really remains an incurable disease for most people. Most pregnant people who have hepatitis B infection don't have any risk factors, and in general, 50% of people who have hepatitis B don't know they have it, and a third of them don't have any known risk factors. 50% of infants who developed hepatitis B infection were not found by perinatal screening, and 20% of infants with hepatitis B infection had no positive household members. So screening has a nice sensitivity rate. It's 97 to 100%. But that few percentage points is meaningful when you are universally screening all pregnant people. The test can be falsely negative, and people can get infected after they have screened negative as well. And remember, not all transmission comes from the mother. So having a mother that tests negative does not remove all risk to the baby. Hep B vaccination has been evaluated and reevaluated for 40 years. And with the introduction of hepatitis B vaccination, our rates have precipitously and steadily declined. But it wasn't until the universal birth vaccination dose was introduced that we got down to a decrease of 99% here in the US. Vaccination works quite well, and if a baby is born to a mother who has hepatitis B infection, vaccination plus immune globulin decreases infection rates by 83 to 97%. There aren't studies to assess the efficacy and durability of an interrupted vaccine series, so it's unclear why the ACIP would suggest that change if they are focused on evidence-based medicine. There are studies that show that seroconversion is proportional to the number and timing of doses. For example, seroconversion is 25% with a single dose, 63% with the second dose, and 95% with the third. And durability of seroconversion is associated with higher titers, and higher titers are associated with the number and timing of doses that someone has received. So again, there aren't data to suggest that stopping the series based on a titer would be safe as suggested by the ACIP. The authors in this paper also extensively reviewed the literature and databases to assess for adverse effects of the birth dose of hepatitis B vaccination, and they were unable to find anything to suggest that serious or life-threatening adverse effects occur with that birth dose. So long story short, in order to get the protection that's needed, the universal dose of hepatitis B vaccination at birth makes the most sense. The thing to remember here with this situation and really any vaccine suspicious issues is that people are trying to solve a problem that doesn't exist. There aren't lots of people dying or being seriously injured from vaccines all the time, such that we need to come up with these altered schedules or vaccine avoidance entirely. We know that these vaccines are safe and they're effective. They save lives. They improve lives. They're recommended at the time and place for a reason, to give people the protection they need at the time that they need it. So keep up the good fight. Educate yourselves, educate your patients, help people understand how important it is to do things that are recommended by evidence. Well, that about does it for this episode of ID Talk. Thank you again for listening. Arizona AAP members can submit questions for future episodes to id@azaap.org. For more information and resources related to infectious disease and immunizations in Arizona, or to become a member, please visit azaap.org. Thank you for all that you do, and we'll see you next time at the next ID Talk podcast.